Hi everybody, it's Dr. Daniel, and today I'm talking about familial hemiplegic migraine. Well, this is a condition associated with migraine, so it comes with one-sided severe throbbing headache, oftentimes associated with nausea and vomiting, a sensitivity to sound and light, where you can't get out of bed, you can't get up, you're disabled, and you're paralyzed on one side of your body. That's what makes it much worse. So how does the International Classification of Headache classify this or talk about it? How do you make a diagnosis of this? And I'm going to abbreviate it as FHM, familial hemiplegic migraine. Well, you got to have two attacks of it. They have to have our weakness has to come with reversible sensory symptoms, other migraine symptoms, like numbness and tingling, one side, fingers, arm, face, or trouble talking, or the visual attacks, flickering lights, spots and holes, and things like that. You're going to have two occurrences of one or more other symptoms that develop over 5 minutes. And these symptoms have to last more than 5 minutes, but less than 24 hours. You got to have a headache within 60 minutes, the onset of an aura. And these headaches could last, like migraine, 4 to 72 hours when they occur on one side, and they're just typical migraine. And you got to have one close first or second degree relative with FHM and no other likely cause of this. Now the problem is it's genetic, and there are 3 genes that currently have been isolated, have it, and there probably more in the future. If you go to my webpage, drmigraine.com, I have the genes listed there. But there's also a sporadic type that can occur from people that don't have a family history. So what kind of inheritance comes with this? It's said to be an autosomal dominant inheritance, which means half of children that are affected are going to have it. What triggers an attack? Something like 50% of patients who get this have a small bump on their head that's not concussive and not knocked out. It's just a mild bump. Well, is FHM confused with other neurologic conditions? Yeah. It comes with brainstem involvement along with typical migraine with aura symptoms, which always kind of is confusing. A lot of folks who have the aura symptoms of numbness and tingling on one side of the body, patients can't really differentiate between numbness and weakness sometimes, and they'll pop into the ER to get scanned and get checked over what they think is a stroke, and it's really just a migraine attack. They can also have disturbed consciousness, coma, confusion, fever. Sometimes if you tap them, they had increased spinal fluid cells called pleocytosis, which normally you shouldn't have. They can have trouble with memory and energy and attention. They can last months after an attack. Some cases have cerebral edema, which is a serious condition, and that mainly occurs at the head injury group. There could be overlap with other kinds of neurologic symptoms. So they get an ataxic syndrome. It's called ataxia type 2. They can get spinocerebellar ataxia, benign familial infantile epilepsy, and alternating hemiplegia of childhood. These are all neurologic things. So are there any long-term side effects from this? 20% of patients may develop ataxia, which involves trouble walking and balance. And the other group of patients can have nystagmus, which is jerky movements of the eyes. It's kind of permanent with that. So what is causing this? What's the pathophysiologist thing? Well, it's just like attack of migraine with aura. It's said to be a spreading wave of depolarization that goes across the brain, where the neurons and glia are all kind of knocked out for a period of time, then they come back, they reset. What's the result of a neurologic workup for this? Well, an EEG on the side opposite to paralysis, like if I'm weak and paralyzed on my right side, the left side of my brain would show slow rhythms for EEG, which measures physiology, and also scans like an MRI scan, particularly if it's timed around the event, like it's an hour or so after the event starts or a day or so later. You can see that. And I have a good picture of this of an MRI scan on my webpage if you want to go look at that. But you can get cerebral edema with cortical enhancement and T1 gadolinium enhancement, which goes away when you rescan it after several days. What's the differential diagnosis? It could be a migraine stroke or an infarct. It could be K-cell. This is cerebral autosomic dominant arteriopathy with subcortical infarcts and leukoencephalopathy. Or it could be a cerebellar degeneration continuum starting and it's slowly advanced. How do you manage this condition? Well, you tell the family and the patient to avoid minor head injuries and all activities, so they shouldn't do any kind of contact sport. You can't treat them with ergotamine or triptans because that's contraindicated. And you can just use simple drugs like over-the-counter drugs like NSAIDs, Tylenol, Advil for pain relief. It might be helpful to use aspirin for its stroke-like prevention qualities. Acetaminophen has some effect on it in some patients. And then the last thought would be, what's the epidemiology of this condition? Well, migraine occurs in 15 to 20% of the world population. With this condition, it's apparent in 0.1% of patients. So it's a pretty low-risk thing there. So that's all on this. If you want to check my blog site out, I have a lot more data there and pictures and everything. Thanks for listening to this. Please subscribe down there, and I'll see you again on the next talk.